Hi, this is Brian Kim. I'm going to share with you this case of a patient who had an Iris-Sutured star three-piece lens. And I performed this surgery on this patient several years ago. He came in to see me aphakic, and so he had very good uncorrected vision with this iris fixated lens about 2025. Very happy, but then he came in with blurry vision, and I noticed that the lens was dislocated. And so at the time, the scleral fixated technique wasn't available, and I performed the Iris-Sutured technique. And I also put in this star three-piece lens because it has a larger diameter. It's over 6 millimeters. But you will see choosing this lens may have been a liability. So you can see that this lens is dislocated. You can see the iris suture tension marks right there with the red arrows. And so you can see that's where I put the sutures, and the sutures are still intact, but unfortunately one of the sides, the haptic has slipped out from the grasp of the suture. So I'll go ahead and make my incisions, and I'll use those incisions to help me explant this lens. And I go ahead and start marking for my intrascleral haptic fixation technique. The caliper is set at 2.5 millimeters. I'm marking at the limbus and 2.5 millimeters posterior to that in radial fashion, and then 2 millimeters adjacent to that. I use a cannula to help find 180 degrees apart, and then I indent the sclera with the caliper in similar fashion. Again, marking 180 degrees apart from the first marks on the right side, and then marking at the limbus 2.5 millimeters back, and then 2 millimeters adjacent. So this is the paracentesis incision to externalize the leading haptic, and this is the incision for my AC maintainer. I'm going to bend the right needle. The right needle is going to be bent about 9 millimeters from the tip, about 80 degrees, and the bevel is going to face towards me. And this is the needle for the left side, and the bevel is going to face away from me. Again, the bevel is always going to be facing the approach of the haptic. This is a 25 gauge needle to help me externalize a leading haptic. This is intracameral lidocaine and epinephrine. You can see the lens is jiggling there. This is some dispersive viscoelastic to protect the corneal endothelium. And this is a 3 millimeter keratome blade. And I'm sitting, this is the patient's left eye, I'm sitting supratemporally. So these are micro forceps. I have 2 forceps now. I'm grabbing the edge of the lens. And so as I was saying, this lens has polyimide haptics, and you know that because they have this characteristic brown colored haptic, and those haptics are known to shatter or break over time when they're in the eye. And so I was very concerned that what if there's shards that fall into the back of the eye as I maneuver with this lens. But thankfully here I'm able to capture the optic anterior, and then I'm going to use a Maltzman in the left hand while using the right hand to hold the lens. I'm going to try to pop that haptic up on the left side first. There you go. And then grasping the optic with my left hand, but then I noticed something. You can see that the haptic actually just came off of the optic right there. So it's like, okay, where's the haptic? Well, the haptic is actually right in the middle of the pupil right there. So I'm like, okay, well, thankfully it hasn't fallen into the back of the eye. And my fears were confirmed that, these haptics are not stable at all. And so in retrospect, I probably shouldn't have used this lens, but at the time it has the large diameter lens. And when you're iris fixating lenses, it's really important to have a good diameter. And so luckily though, I was able to grasp this remnant and gently slide it. It's actually still incarcerated into the iris suture. So that right side must have been the one that was still secured to the haptic. And I'm just gently positioning it. It's underneath the optic here. I'm gently repositioning it so I can take it out. You have to be very careful with these haptics because they can break so easily. So again, this polyimide material, it has that characteristic brown color, unlike the other materials which are blue. So you can see I'm using two forceps and I'm just gently just tugging on it, and you can see it's just kind of falling apart. So polyimide is really, in my opinion, a bad material, and moving forward, I will probably never put in a lens that has polyimide haptics. So my recommendation is to avoid any haptic that is brown colored if it is made of polyimide. So then I grasp the optic with my left hand with the forceps, and then I'm cutting the lens with the scissors in my right hand. I'm going to bisect it completely since the lens is in the AC. Switching hands with my right hand to forceps now. I'm carefully re-grabbing, and I'm not quite sure if this lens is made of silicone, but if it is, sometimes it's slippery to grab with the non-serrated toothed forceps, and so I think I switched hands there to grasp that right side piece, and then I'm going to grasp with the forceps on my right hand, and then I'm going to do a twirly move here. You saw that twirly move. That's a two-handed twirly move, so I can rotate that piece so the optic and haptic can come out and the haptic can collapse easily like it did. So I'm hydrating that incision and then making some more incisions for the iris hooks. You can see the pupil's quite small, and I'm planning to put in a Sensar lens. And I really like using the Sensar lens. I feel like the Sensar lens, the haptics grip the needle really nicely when I'm doing the Yamane technique. And so I like to put some hooks in to get better visualization. Unlike the C2 Lucille lens with the polyvinylidene Florida haptics, those haptics are really, really strong, and you can beat them up pretty easily and not cause any damage to the haptics. Whereas this, the Sensar lens with the PMMA, you have to be more delicate with them. By retracting the pupil, I'm able to manipulate the lens with minimal trauma and minimal trauma to the haptic. And so you can see I'm placing the lens into the cartridge here. You want to make sure it's seated down, make sure the haptics are down as well. And as you close the cartridge, you want to make sure that leading haptic comes out pointing straight into the barrel. My assistant's going to help me slowly advance the lens. With my left hand, I have the 25 gauge bent needle bevel to the right. I'm placing the cartridge into the incision. She's going to start advancing the lens. As she does this, the haptic is going to come out facing to the left. I'm going to dock the haptic on the bevel of the needle, straighten it out, and as she advances the lens, atraumatically and very gently, the haptic comes out. Once it comes out, I'm able to take over and start advancing the optic, making sure the optic comes out planar, and then I sweep the trailing haptic towards the right, make sure it comes out in the correct orientation, push some more viscoelastic, some dispersive viscoelastic to push the lens away from the corneal endothelium, and then you want to give it some time to unopen. And you want to make sure that optic is completely flat, it's not tacoed still. And once it's flat, go ahead and grab the incision here, and then with the right side needle, I'm going to stick it into the sclera, tunnel it, partial thickness, 2 millimeters, and then dive straight back. And you want to stay in that same plane. You don't want to rotate quite yet. You want to clear the ciliary body first when you're piercing through the sclera. And you can see because I've retracted the iris, my view is much easier here. And using microforceps, I can very easily cannulate that haptic through the needle. I dock the haptic on the bevel of the needle and it goes right in. Again, a very gentle touch is required, otherwise you can damage the haptic. Disengage the needle from the syringe using microforceps to internalize the leading haptic. And using this lens to me has a lot of advantages, but it does require really a gentle technique, and you have to be very, very subtle with your movements. You can't be heavy-handed at all. So grasping the incision with the right forceps with the needle on the left side. I'm going to enter through the sclera, tunnel 2 millimeters, and then dive down. Again, I'm staying in that same plane. And once I penetrate, and then I rotate, again, to avoid the ciliary body. Because of the way I retracted the iris, you can see I have a really nice view of the needle. Very carefully with microforceps grasping the haptic. And you'll see, even though I don't grasp the haptic all the way at the tip, because of the concept of docking the haptic on the bevel of the needle, I'm able to confidently dock it without causing any damage or stress on the haptic. So again, I'm flattening it out. You can see that flattening right there. Flattening. Because it's docked, it actually kind of holds it, even so you can actually re-grab it pretty easily. And then I'm advancing the haptic through the needle. Again, if it doesn't go in, it's because you're not straight. So you have to kind of very subtly reposition the two hands so that both the haptic and the needle are facing each other. And then you want to pull the left hand down towards you and the right hand up away from you. Again, it's in the same trajectory and path in which you cannulated the needle through the sclera. And as you do this, you can see the haptics coming out. Very carefully, I'm making sure that not too much of the haptic comes out because it'll put stress on the other side. And then I cauterize the tip and create a small little bulb. And then I do the same thing on the other side. You can see I'm going to push that haptic a little bit in, and then I'm going to go ahead and go after the right side, holding it with the forceps, and then cauterizing the tip. Again, for some reason, these PMMA haptics don't tend to slip back through the sclera, whereas the polyvinylidene fluoride haptics of the C2 Lucia, in my experience, do tend to slip more. And so, you know, these lenses are readily available. The Sensar lens, a lot of people have a lot of experience with it, and I've really enjoyed using this lens. But again, you have to have the right technique in order to do it. And I've been using this lens for pretty much most of my cases now, and I've really enjoyed it because, like I said, the haptic doesn't tend to slip back through the sclera, and it's a very reliable lens, a very good lens. So you can see I'm taking the iris hooks out one by one, and you want to be able to take it out in such a way that you don't damage the hook. Sometimes you have to turn it the other way. There you go. So I'll go ahead and hydrate the incisions here. This patient has had a vitrectomy in the past, a true core vitrectomy by a retinal specialist a long time ago. That's why he came to me aphakic. He had an injury to the eye a long time ago. And so no reason to put trocars in and do a vitrectomy because he's already been vitrectomized. But take the AC maintainer out, go ahead and place a tendon-nylon suture. Again, I do that out of habit. I think it's a good habit to have, and close that main incision. And because, again, he's already had vitrectomy, I go in with the INA handpiece. You can see I reduced the bottle height to IOP of 20. And so you have a lot less trampolining of the iris. And you can see I'm able to really nicely remove all that viscoelastic from the anterior chamber and coating the cornea. And then as I come out, I push BSS in. You can see I didn't tie the suture off yet. Go ahead and hydrate the incisions and then close that incision with the suture, bury the knot, and that's basically the end of the case. So again, this is a patient who had Iris-Sutured lens with this star 3-piece lens with polyimide haptics. Again, larger diameter optic, about over 6 millimeters, but unfortunately very delicate haptics. Luckily I got away with it. It didn't cause any problems. I didn't lose a piece into the back of the eye. I was able to get the whole lens out, bisecting it, and then using my modified technique of scleral haptic fixation and using the Sensar lens to refixate the lens. This patient ended up very well. He was uncorrected 20/30 at the end of the case, and he's very happy. I told him, we did the best we could with the Iris-Sutured technique, but this is the latest and greatest. And I told him by anchoring the arms of the lens to the scleral wall, that this lens is not going to go anywhere anymore. And so I hope this will be the last time he ever has to go through this. And I'm feeling really confident that this is going to be hopefully the last case that he is ever going to go through regarding his lens implant in this eye. So I hope this was helpful to you, and I thank you for your attention.